for the course directives for this course. Over to them.
Thank you very much, Hari and Vijay Chopra and Professor Vijay Raghavan. Ladies and gentlemen who have joined us today for our heart failure meeting. It's a real pleasure to have you with us. The first session as we start on heart failure, we'll open up with our President, Dr. Hari Krishnan, and we have three very important topics. We are going to talk on the pathophysiology and the Indian scenario of heart failure. Then we have Professor Dr. Gisa Prozano will talk to us about the phenotyping of heart failure. And then Dr. Professor C. Manjunath from Jayadeva Institute at Bangalore will brief us on how do you interpret ECG, X-ray, and the 6 minutes walk test. So it's basically a very good clinical profile aimed at how do we translate in clinical practice what we learn on the screen in the PowerPoint presentations. So with this words of welcome and thank you for our experts who are here today, may I invite my co-course director, Dr. Bhagirath Raghuraman, to say his few words and then take forward the pre-test. Please concentrate on the pre-test. Thank you very much.
Good evening, everybody. Yes. Respected Vijay Raghavan sir, respected Chopra sir, Dr. Uday sir, and Dr. Hari. I think it's with great pleasure that I am part of this elite group and team, and all of us have worked to put together this course. We have numerous luminaries from all over the country who are the best in the subject, who are deliberating on various topics which are extremely useful in day-to-day practice. So without wasting much time, I will get into the pre-test. This is basically designed to give you an insight into where exactly you stand in this journey of heart failure. So we don't mean to belittle anyone's knowledge. We don't mean to publish the scores to show where exactly you stand. It is in fact designed to be a self-assessment so that you can understand where you are, so that ultimately when you take the post-test, you can understand how much more you've improved and how much your understanding of heart failure is improved. So with these few words, I think I'll get straight into the pre-test questions.
And also the answers will be given at the end.
Answers will be given at the end of each question. So I'll start. So the first question is, what is the commonest etiology of patients admitted with acute heart failure in India? There are 4 options. Let me say that I'm giving you options A, B, C, and D. About 10 to 15 seconds to answer this, after which I will give you the answer so that you can check what is your assessment and what is the correct answer with the reference. We have 25 questions in this pre-test series, so that we have a few minutes for each of the answers. And at the end of it, I will hand over to my course director, Dr. Uday, so that he can proceed with today's lectures. So the first question is, what is the commonest etiology of patients admitted with acute heart failure in India? Options A, B, C, D. Rheumatic heart disease, dilated cardiomyopathy, ischemic heart disease, and untreated congenital heart disease. 10 seconds for your answer. Okay, so the correct answer is option C, ischemic heart disease, Trivandrum Registry, National Heart Failure Registry. So we all know that there's a big population with ischemic heart disease. These are the survivors of an acute MI who have primary angioplasty, and invariably most of them survive a massive heart attack, but they are able to, they soon get into the group of ischemic cardiomyopathy. And from there on, it depends on what is the time to door to balloon time, so that that eventually determines what is their LV ejection fraction. Next question, 1-year mortality of patients with heart failure according to the Indian registry data is option A, 5%, B 10%, C 20%, and D 30%. Time starts now. 10 seconds. Correct answer is option D, 30%. This is the data from the Trivandrum Heart Failure Registry, which has shown that 1-year mortality is 31%. Our president, Dr. Harikrishnan et al., has published this data, which was published in American Heart Journal 2017. Next question is, what percentage of patients who present with heart failure have preserved ejection fraction, HFpEF? That is the EF more than 50% in a developing country like India. So I want to know what is the statistics or the data that we have regarding the prevalence of heart failure with preserved ejection fraction. So the options are A, is it 10 to 20%, B, is it 20 to 30, C, 30 to 40, or D, 40 to 50%. 10 seconds. The answer is 10 to 20%. So option A, National Heart Failure Registry again. Next up, a 45-year-old asymptomatic gentleman evaluated for hernia surgery was found to have LV systolic dysfunction, EF of 45% on echo. He is said to be in which stage of heart failure as defined by the ACC-AHA criteria? So is he in stage A, which is option A, or is he in stage B, stage C, or stage D? 10 seconds. EF of 45% on echo, asymptomatic, chance finding, pre-surgery. The correct answer is stage B, structural heart disease, but without signs or symptoms of heart failure. That is LV dysfunction, LV hypertrophy, and so on. This is published in Circulation 2001. Next question, the physical sign with least specificity to diagnose heart failure in adults. So these are the various physical findings. Option A, bilateral pedal edema. Option B, positive hepatojugular reflux. Option C, cardiomegaly as indicated by laterally displaced cardiac apex. Or option D, left ventricular third heart sound. 10 seconds. Correct answer is A, bilateral pitting pedal edema. We all know that you can have pitting pedal edema in a variety of conditions. So the other three are relatively more specific for heart failure. Next question, which of the following medications used for heart failure with reduced ejection fraction, that is congestive heart failure, does not reduce mortality? Is it ACE inhibitors? Is it beta blockers? Is it aldosterone antagonists? Or is it option D, diuretics? 10 seconds. I'm sure almost all of you know this answer. The correct answer is D, diuretics. Diuretics have shown that there's no mortality benefit, only symptomatic benefit. Most of us are already aware of this, and this is the reference to say so, EHJ 2016. Next question, one of the following beta blockers are not recommended by the various societal guidelines to treat heart failure with reduced ejection fraction, that is congestive heart failure. Is it metoprolol tartrate? Is it metoprolol succinate? Is it carvedilol? Or is it bisoprolol? Which of them? This is the explanation. Answer A, metoprolol tartrate. Not all beta blockers have clinical trials to support their use in systolic heart failure. Only metoprolol long-acting preparation, that is succinate, is recommended, not the short-acting ones. Hence, the correct answer is metoprolol tartrate. We all know that there's a wealth of evidence to support use of carvedilol and bisoprolol. So option A, is the right answer. A 30-year-old patient comes to the emergency department with acute dyspnea. You order NT-proBNP test to rule out heart failure. Which value is diagnostic of acute heart failure as per the guidelines? Is it option A, more than 35 picograms per ml, or option B, more than 100 picograms per ml, or C, more than 125 picograms per ml, or option D, more than 300 picograms per ml? So the correct answer is answer D, more than 300. We all know that acute heart failure, the BNP value 100 picogram per ml, and NT-proBNP is 300 picogram per ml. In chronic heart failure, the values are BNP of more than 35 or NT-proBNP more than 125. So deliberately, all these values are in a way correct, but the answer that we are looking for is option D, more than 300. This is the EAC guidelines validated answer. Next, which among the following has the least risk of causing hyponatremia? All of us use diuretics in management of heart failure, and hyponatremia is invariably a problem that we all encounter. So which of these has got the least risk of causing hyponatremia? Is it indapamide? Is it chlorthalidone? Is it hydrochlorothiazide? Or is it furosemide? And the correct answer is furosemide. Thiazides, we all know, cause more hyponatremia than loop diuretics, and this is a nephrology journal reference of 2017. What level of dietary sodium restriction will you advise your patients with symptomatic heart failure? The options are A, 2 grams per day, option B, 4 grams per day, C, 6 to 8 grams a day, or option D, 10 to 12 grams a day. Please read the question carefully. There is a catch in this. Dietary sodium restriction. The answer is A, 2 grams per day. That is 5 grams of NaCl. That's the correct answer, and that's the catch. Next, let's look at a clinical scenario. You started ACE inhibitors in a patient with heart failure. Baseline creatinine was 1.5 milligram per deciliter, but as we are all aware, it soon becomes 2 milligram per deciliter after 1 week. Urine output is normal. Serum potassium is also normal. What to do? So the various options are: first, withdraw ACE inhibitors. We all know that they are incriminated in the worsening of the renal profile. So should we withhold the ACE inhibitors? Or let us half the dose of ACE inhibitors. We have many physicians who take this approach. So is that the right approach? Option B. Or is it option C? Continue the same dose and monitor closely. Watch for a little more time. Or D. Change to an angiotensin receptor blocker. Withdraw it, half the dose, continue same dose, or change to AR. What would you do? So the correct answer is C. Continue the same dose and monitor closely. Up to 50% increase or absolute value of up to 3 milligram per deciliter. We all know that there can be a transient worsening. This should not trigger a panic button wherein we steal away whatever benefit the ACE inhibitor is giving to the patient. So best thing is to continue the same dose and monitor closely. And you can have an absolute value of up to 3 milligram per deciliter before you take decisive action. Next question, the current role of digoxin in heart failure with reduced ejection fraction. Which of them is true? Option A, it reduces mortality. Option B, reduces re-hospitalization. Option C, it benefits heart failure patients in sinus rhythm. Or option D, 0.25 milligram is the initial daily recommended dose as per the ESC guidelines. So what, in your opinion, is the current role of digoxin in heart failure with reduced ejection fraction? Also, the purpose of this question is, in case it doesn't meet the requirement, whether to stop the digoxin. So if we get the answer to this question, we know exactly what to do in a patient who arrives with a prescription of heart failure medications. So the answer is B. Digoxin has not been found to reduce mortality, for sure. It only reduces rehospitalization. So definitely arguing that it reduces mortality is not acceptable as per the guidelines. It benefits patients in atrial fibrillation and not patients who are in sinus rhythm. Further, the recommended dose is 0.125 milligram as per the ESC guidelines and not 0.25 milligrams. So this has to be kept in mind, and this is how we proceed as per the guidelines in the management of heart failure, particularly deciding on the role of digoxin in your patient with heart failure. Next question. Your patient with heart failure with reduced ejection fraction is on metoprolol XR, that is the extended release, 200 milligram once daily. He's also on sacubitril valsartan, 200 milligram twice a day, and spironolactone, 25 milligram once daily. Heart rate is 82 beats per minute. What would you do next? Would you add digoxin, that is option A? Would you add ibuprofen, option B? Would you add a calcium channel blocker, option C? Or would you change to carvedilol, option D? What would you do in this clinical scenario? I think this is a pretty straightforward question. We all know that the answer is option B, ibuprofen. We have enough societal guidelines and data to support this. Next question. All among the following are physical findings used to assess fitness for discharge in a patient hospitalized with decompensated heart failure, except. So supposing you find a patient with normal JVP, is it time to send him home? Option A. Or option B, no dependent edema. Option C, no lung crepitations. Or option D, attainment of normal BNP values, which according to the guidelines is a criteria to send the patient home, except. Okay, so the answer is D, attainment of normal BNP values. We all know that 30% decrease in BNP value is taken as criteria in some of the studies. That is Ambrosi et al. Everest trial, Eject 2013. Most of us know that BNP values take quite some time to settle down. So if you have the other criteria, then probably it's time to send the patient home, depending on clinically how fit he is to be managed medically at home. Next question regarding transplant. What is the 10-year survival of a post-cardiac transplant patient in established transplant programs? 10-year survival. Is it A, 80%? Is it B, 60%? Is it C, 40%? Or is it D, 30%? Remember that this value decides how good a transplant center is. Most centers in the US, the continuation of the license to have a transplant program depends on this value. So the answer is option B, 60%. This is the JHT online article. This is essentially the ISHLT data. Most of the ISHLT data is reflected in the US patients. Of course, we have now have good statistics in India as well. Many centers have transplant patients who have crossed 10 years, though not very big numbers. So we'll soon have our own statistics and data to have national values. Which is the drug that has shown significant survival benefit in heart failure with preserved ejection fraction, HFpEF? Heart failure with preserved ejection fraction, EF more than 50. So which of these medications has shown significant survival benefit? Is it option A, beta blocker, option B, digoxin, option C, ivabradine, or is it none of the above, option D? So the answer is D, none of the above. As per the data available, no drug has found to be effective in improving mortality in heart failure with preserved ejection fraction. Next, a patient with heart failure presents with acute decompensation. BP is less than 70 millimeters of mercury. Which inotrope would you start? We all know that you have a big range of inotropes that are available in our ICU setup. So which would be your preference if the BP is less than 70? Would it be A, norepinephrine? Would it be B, dopamine? Would it be C, dobutamine? Or lastly, D, would it be levosimendan? So the answer is A, norepinephrine. This has been published in Circulation 2008. Next question, regarding fluid restriction in heart failure. One of the following is not true. Option A, fluid restriction is recommended in patients with severe congestive symptoms. Is it true or not true? Next, it is useful in hyponatremia. C, usually restriction of 1.5 to 2 liter of fluid is recommended in 24 hours. Or D, routine fluid restriction in mild to moderate symptoms is recommended. So which of them is not true as per the guidelines? So the correct answer is D. Routine fluid restriction in mild or moderate symptoms is recommended, is not true in, that is, mild to moderate symptoms. Only in severe it is recommended. So this is not true. Option D. Target dose of ramipril in patients with heart failure with reduced ejection fraction is A, 2.5 milligrams, B, 5 milligrams, C, 7.5 milligrams, and D, 10 milligrams. I think most physicians will get this right. The message from this question is to keep escalating till you arrive at the desirable value. So the correct answer is 10 milligrams. This is European Heart Journal 2016. So we keep escalating, keep an eye on the renal profile, keep an eye on the potassium, and keep increasing the dose of ramipril to reach a target value of 10 milligrams in patients with heart failure with reduced ejection fraction. Regarding therapy with ARNI, which of the following is true? Option A, if a patient is on angiotensin receptor blocker, it should be stopped for 48 hours before starting on ARNI. Next, target dose is 200 milligram BD if tolerated. C, BNP should be the preferred biomarker rather than NT-proBNP. And lastly, it can be safely used in patients with hepatic impairment. Which of them is true? Carefully read the options. So the correct one is option B. If a patient is on ACE inhibitor, it should not be stopped. It should be stopped. NT-proBNP should be preferred as sacubitril degrades BNP. So this is the message from this question, which leads to false elevation of values. So should be avoided in patients with hepatic impairment. So the correct answer that we are looking for is option B. Regarding natriuretic peptides, what is not true? A, more useful to rule out than rule in heart failure. Option B, we must use higher cutoff values in obese patients. So if you have a fat patient with heart failure, what would you do? Are there different values? Next, option C, more than 75 years, the cutoff values for NT-proBNP is 1800 picogram per ml. And option D predicts outcomes both in heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So the correct answer is option B, lower cutoff values in obese patients as values are falsely low. So it's not the higher cutoff value, but lower cutoff value. This is what we are looking for. Which is the new anti-diabetic drug which is found to be effective in heart failure and prevents HF hospitalization? Is it saroglitazar? Is it SGLT2 inhibitors, DAPA? Is it pioglitazone? Or is it lulacine insulin? New anti-diabetic drug found to be effective in heart failure. Again, I think most of us are updated and will know the answer to this. So most of us know that the answer is B. From the DAPA-HF study, it is the SGLT2 inhibitor, dapagliflozin. Next, COVID pandemic. In COVID-19, the following statements are true except A, cardiac injury manifests in second week and is a prognostic factor. Cytokine storm is one of the major reasons of cardiac injury. Option C, supply-demand mismatch, that is type 2 MI, is one of the major reasons for cardiac injury. And lastly, option D, type 1 MI due to atherosclerotic plaque rupture is the most common mechanism of cardiac injury. Which of the following statements are true except? So the answer is option D. Type 1 MI is uncommon in COVID-19. All of us know that eventually when we do an angiogram in an acute MI situation with a view to primary angioplasty, we get the answer to this question. This is again published by Dr. Hari et al., who's in the panel. 55-year-old patient with EF of 35% on metoprolol extended release 200 milligram, ARNI 200 milligram, BD, spironolactone 25 milligram, BP 100/70, heart rate of 68, left bundle branch block on ECG, has survived a recent cardiac arrest. Still symptomatic. What would you do next? Are you looking at putting in a CRT-P pacing option? Are you looking at CRT-D defibrillator option? Are you looking at putting in an ICD, or are you looking at a CCM, cardiac contractility modulation? Which do you think would be the best in the next step of management? All drugs are in place. Patient has a left bundle branch block, EF of 35%. Straightforward question. So the answer is CRT-D. We know that we have the MADIT criteria, left bundle branch block, EF 35%, symptomatic heart failure. All of these, and also we have resuscitated cardiac arrest. So pretty straightforward answer. So that's the end of the questions. I think we have a minute left. Dr. Hari, any comments? I think most of the references are from you, as well as the questions are formulated by you. So I think I'll ask you to comment on this.
Yeah. Thank you, Bhagirath. I think I hope it will be useful to the to the participants.
Chopra sir.
So Dr. Bhagirath, very nicely done, and Dr. Hari.
Good evening, Manjunath sir.
Yeah,
Good evening, sir. Yeah.
So it is just a refreshing. Okay?
Yes, sir. Yes.
Yeah.
Good
Dr.
evening,
Chopra, you are
Dr.
muted.
Vijayaraghavan.
I think that was a very nice set of
Yeah.
questions.
Very
Which
practically oriented.
To test the basics.
Yeah.
As Dr. Bhagirath mentioned right in the beginning, it is basically to let you assess yourself, so that at the end of the test, at the end of the training period, there would be another test, and then we can see how things have improved. So I think let's go on to the main session. Professor Vijayaraghavan sir, all yours.
Sir, you're muted, sir.
I think we have 3 lectures with 20 minutes talk and 10 minutes discussion. The time is very tight. I think we'll go ahead with the first lecture by Hari Krishnan, Heart Failure in Indian Context and Pathophysiology of Heart Failure. Dr. Hari Krishnan, please.
Good evening, respected panel, chairpersons. First of all, I thank Dr. Uday and Bhagirath. First thing, what I want to discuss is why heart failure is important. We know that it has become a global pandemic. Around 26 million people worldwide. We take the US prevalence, it is 2.2% in the US population. 1 to 2% of the total global health expenditure is on heart failure. And more than 10% of the total health expenditure for cardiovascular disease is spent on heart failure. So it is very important, both on a health perspective and a health economic perspective. It impacts the health systems and society, because we know the therapy is resource intensive. The reach or access to the therapy is limited. Most of the patients need lifelong treatment. High mortality, 30% at 1 year and 60% at 5 years. It is higher than common cancers like breast or colon. The economic impact is high, and there is significant loss of productivity. That is why heart failure is important. We will see the burden of heart failure in India. There is no real data on incidence or prevalence. If you take the US prevalence of 1.8% in 2019 and extrapolate to 800 million Indian adults, the number of people with heart failure could be 14.4 million. That means 1.4 crore patients with heart failure. What could be? We will go to some projections and see what could be the current burden and what are the projections. We know that heart failure burden increases with the age. This is the age-wise prevalence of heart failure. You can see that at 80 plus, it is around 12 to 14%. So you see the Indian population 2011, above 60 years, it is 8.3%. In 2051, the above 60 population is going to be 21%. So naturally, the heart failure burden is going to rise. Risk factors for heart failure: We know diabetes is rising like wildfire. You can see the southern states all in red. The prevalence is reaching almost nearly 20% in some of the states. Hypertension is on the rise, obesity is on the rise, and coronary artery disease prevalence. You can see the Indian prevalence is similar to the Eastern European countries. And we can see that the data from Kerala, Trivandrum, shows that the prevalence in 1993 was 1.4. The same population was evaluated in 2016. In a gap of 23 years, you can see the prevalence has increased to 250%. Data on all diseases, rheumatic heart disease is still a significant burden. We are going to see in subsequent slides. Congenital heart disease, 180,000 children born with congenital heart disease. 1/3 have critical disease, and most of them have a repairable defect like a simple VSD, ASD, or PD. And unfortunately, many of them are not getting treatment at the correct time, leading to irreversible pulmonary hypertension. We know the issues related to corrective surgical procedures. Some etiologies are more common in the Indian context. For example, endomyocardial fibrosis, which is endemic in some areas like Kerala. Emerging infectious disease epidemics. Leptospirosis, 4% had heart failure. Dengue fever, this is the data from Professor Vijay group. Myocarditis, 13% of the patients had EF of less than 40. You know what is the magnitude of dengue fever happening in our country. COVID-19, we know so many patients coming with heart failure, there is emerging data. Pulmonary hypertension due to various etiologies, especially COPD, infective endocarditis, peripartum cardiomyopathy, aortoarteritis. These are all common in the Indian context. And anemia, which is very common, can aggravate heart failure and contribute to it. So heart failure in India is a double burden. We can say it is a double burden, the heart failure, because there is a rise in the prevalence of the risk factors and persistence of old age diseases. That is why it is called a double burden. The burden is likely to be high currently, even though we don't have enough data, and likely to be more in the younger population, as we are going to see. Now we will see some Indian data on heart failure. We will have the data sets like the Trivandrum Heart Failure Registry, the Inter CHF, where 858 patients from India was there in the multinational registry. We have the Kerala registry. We have the Indian College of Cardiology registry and the Medanta registry by Dr. Chopra. And the latest data set, which has a national representation, is the National Heart Failure Registry, which we are currently doing with support of ICMR. So this is the study architecture of the National Heart Failure Registry. You have the red stars indicate the nodal centers, which are teaching hospitals in that particular region. And each nodal center will have 5 centers around them. They are called the participating centers. Each center will recruit 200 patients. So we have already recruited around 10,000 patients. The 6,400 patients data we have presented in the ESC meeting as a late-breaking trial, a session. The data shows that the mean age is around 60 years, 60.5. Men contributed to around 70% of the disease burden. How do the ejection fraction classification pattern in our patients? Most of the patients have a heart failure with reduced ejection fraction. Around 2/3 of the patients were having heart failure with reduced ejection fraction. Preserved ejection fraction, very low, 12 to 16%. But you compare with the US data, you can see that the preserved ejection fraction is very high, 35 to 46%. That means that our preserved ejection fraction group is lower. Reduced ejection fraction is higher compared to the Western population. Male-female ratio, it is 70-30 in the Indian setting, while it is 50-50 in the US population or the European population. This is the age profile, which is interesting. You can see that the National Heart Failure Registry showed it is around 60 years, 60.5 mean age. But you can see the US and the European data, even Chinese data. The HERO study showed it is 72. European study 69, 73, 72. This means that our patients are 10 to 12 years younger than the Western patients. This was seen in the other Indian registries also. What is the etiology? There was a question in the pre-test. What is the commonest etiology of heart failure? Ischemic heart disease contributed to 73%. Dilated cardiomyopathy 17%. rheumatic heart disease around 6%, and non-valvular heart disease around 2.3. So these three diseases, ischemic heart disease, dilated cardiomyopathy, and valvular heart disease, mostly rheumatic, contributed to more than 95% of the burden of heart failure in India. So these three diseases, ischemic heart disease, DCM, and rheumatic heart disease. What is the risk factor profile of our patients? Hypertension, 48.5 compared to this US data and the European data, 73% and 76%. Probably this reflects the higher age of the population in the US. Diabetes mellitus, almost the same. Tobacco use, half of what is there in the, double that of what is seen in the Europe. And alcohol use is half of what is in the Europe. Atrial fibrillation is only 10%, probably because of the lower age of our population. What is the medication use pattern in our patients? The beta blocker we assessed in 73, ACE or ARB in 56, aldosterone blockers in 70%, ARNI in only 4% of the patients. And if you take the guideline-directed therapy as a combination of ACE inhibitor, ARB or ARNI, either of them, plus beta blocker, plus ARB, 41% of the patients only in reduced ejection fraction group received the therapy. So we are under prescribing our patients with the guideline-directed therapy. That is very, very important. That is one of the aim for this course, to improve the guideline-directed therapy. What is the in-hospital mortality? The Trivandrum and the National Registry showed it is around 8.5, but it is significantly higher than the European and the US data, around 3.8 to 5.5. It is significantly higher. 90-day mortality in the National Registry, it was 17.1. Trivandrum Registry, it was 18. So how the guideline-directed therapy affects the mortality? That is the question. We can see that those patients who received the guideline-directed therapy, there is a very significant reduction in mortality. Those who received the guideline-directed therapy has a significant benefit in reducing the mortality. This was also seen in the mid-range or the mildly reduced ejection fraction group, because we know that the mildly reduced ejection fraction group between 40 and 50 go usually along with the reduced ejection fraction. Now we have the long-term data from the Trivandrum Heart Failure Registry. We now have even up to 7 years follow-up of our 1,205 patients. Small number, but we are able to get the long-term follow-up. 1 year mortality is 31%. This was similar to the INTER-CHF study from Indian patients group. 3 year mortality is 45%. And recently, last few weeks back, we published the 5 year mortality, that is 59%. So 2/3 of our patients are not alive at 5 years. This is higher than the Western data, where it is 50% mortality at 5 years, the Framingham data. How do our preserved ejection fraction patients compare with the reduced ejection fraction? In the Western world, both have the same mortality. Preserved or reduced, the mortality long term is the same. But our patients with preserved ejection fraction have a slightly lower mortality, probably due to the prevalence of valvular heart disease, especially rheumatic heart disease in our population. So the mortality trends: 30 to 1 year, 44 at 3 years, and 58, almost 60% at 5 years. So the 10 take-home points from the data from India. There is emerging data from the registries. Indian heart failure patients younger by 10 to 12 years. Male preponderance 70-30. Reduced ejection fraction 65. Mid-range 20. Preserved very low 15. Ischemic heart disease, the commonest etiology, 65 to 70. Dilated cardiomyopathy 15 to 17. Rheumatic heart disease 6 to 8. Mortality in hospital 8. 1 year 30. 3 year 45. 5 year 60. This I made to make it easy to remember. Guideline-directed therapy improves mortality, but only 40%, 25 to 40% of the patients receives that. Readmissions predicts mortality. Preserved ejection fraction, better outcomes. A reason I told you. Quality improvement programs like this course may benefit our patients. Now I will go to some issues in management of heart failure in India. I will classify them into accessibility issues, availability issues, and affordability issues. We know that India has uneven and limited access to healthcare. People living in remote villages, highlands, and islands have limited access. Overloaded public healthcare system. Emergency medical services, ambulance, not universally available, even though there is a significant change recently. For example, our ACS patients, the door to balloon time is significantly longer than other countries. Availability, we know that heart failure requires intensive specialist care, at least in the acute phase. Dedicated heart failure units are there, very good centers, excellent centers with very good outcomes, but they are only few and concentrated in the major cities. Centers which can manage the sick patients are limited. Example, hemofiltration, regular inotropic support, they are limited. Next is affordability. We know that is a resource-intensive treatment, a lifelong treatment, costly therapy. Some of them requires ICU care when they have worsening. For example, device therapy like ICD or CRT is mostly unaffordable. And vast majority of our patients spend out of pocket. Public hospital with facilities are limited, and I've seen they are overloaded. I will show an interesting data from Amit Vora's group. They identified 2,000 patients with heart failure and identified 1,000 patients who require either a radiofrequency ablation or a device. And they followed up the patients and found that 17% of the patients only got the therapy. Either they were not referred or they were referred but could not afford. So that is the situation in the real situation, what is happening in India. So heart failure in India, the burden is enormous, affects the younger from the low socioeconomic status, issues of accessibility, affordability, and availability. So what can be done? That is the most important thing which we have to discuss. Accessibility issues, what can we do? Establishing more centers, for example, heart failure clinics in all district headquarters where it can be helped by the teaching hospitals nearby. Centers of excellence, referral for specialist care. We have no dearth of expertise. We have very good centers, very good, excellent clinicians where we can do cardiac cath, device follow-up, and transplant. Referral system should be properly implemented. When to refer and where. Point of care devices, for example, a BNP device can be kept in the primary health centers. It will help in diagnosis. Affordability, control of drug prices, generic drugs. The Jan Aushadhi outlet is a good thing which is happening. Subsidy or financial assistance for prolonged drug therapy, which is not there. We are giving money only for the acute procedure. We are not following up with for the long-term drug therapy, which is very, very important. Medical insurance, the Ayushman Bharat is a good scheme which is getting implemented. We will see what is the benefit of that. Technology can be used for continuation of care. For example, mobile phone-based follow-up. For example, periodic reminders, for example, a rheumatic prophylaxis. Tablet-based interactive systems for ASHA workers and physicians. Telemedicine, there is a boon to the telemedicine related activities due to the COVID. We can maintain that impetus, and we can do more with heart failure. But what I want to stress is that management, once the disease has occurred, is unaffordable and not accessible to the majority in India, especially in the case of heart failure, where it is a resource-intensive treatment. So we have to go and do things which what United States have done to their population. Through intensive legislations and public health activities, they brought down the prevalence of cardiovascular disease starting from the 1970s. We have to follow those steps to reduce the burden of heart failure. So what can be done? Early detection and treatment of risk factors. Acute coronary syndromes, primary PCO thrombolysis, because 70% of the burden is due to coronary artery disease. Pulse oximeter screening in newborns, that is being implemented, it's a good thing. Early diagnosis and referral will reduce the pulmonary hypertension and heart failure. Secondary prevention of rheumatic prophylaxis should be stressed and followed up. This one point I want to stress, because this is the prevalence or number of people with diabetes and hypertension. You can see they are in their 20s, they are in their 30s. There is no point in doing a health checkup at 30s or 40s and finding that you are having coronary diabetes or hypertension. You would start early in schools. You should cultivate the good habit of regular exercise, stopping smoking, good food, avoiding junk food, and all those things in the schools itself. That will control the burden of the chronic diseases in our society. Secondary prevention is very important, very, very important, because there is clustering of risk factors. For example, that is what we call as the multi-morbidity. Multi-morbidity. Treat all risks together. For example, statins in diabetes. Secondary prevention of rheumatic fever is is an important thing which can be done. Provide continued evidence-based care, ensure adequacy of medications, ensure lifestyle modifications which we all neglect. That will all prevent progression to heart failure. So heart failure in India, we are different. We need different solutions. So heart failure is a huge burden facing the health system in India. It affects younger ages with high mortality. Evidence-based management reduces mortality. Accessibility, availability, and affordability issues are there in India. And prevention, I am stressing again, prevention is the key with focus on control of risk factors. The second part of my talk, I am asked to discuss something about the pathophysiology of heart failure. I will do it quickly because of the lack of time. I will start with the new universal definition and classification of heart failure, which was published a few days back in the Journal of Cardiac Failure. The new definition, there are varying definitions with the ACC, ESC and all. Now this is everybody has joined together and produced this definition. It's a clinical syndrome with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated biomarkers and or objective evidence of pulmonary or systemic congestion. This is the new universal definition. And the new heart failure classification based on EF has also come. Reduced ejection fraction is less than 40. Previously, the mid-range ejection fraction is changed to mildly reduced ejection fraction, that is 40 to 49. Preserved ejection fraction is more than 50. And a new thing has come, that is improved ejection fraction. Those who had a baseline ejection fraction less than 40, there is a significant increase over the baseline. Those patients are called improved ejection fraction. That is a separate category which has come. Now coming to the pathophysiology proper, we have two types of heart failure, the reduced ejection fraction and the preserved ejection fraction. The reduced ejection fraction, we have the contractility is impaired. That is why the cardiac output is not maintained. In the diastolic dysfunction or the preserved ejection fraction, we have the relaxation abnormality, even though the systolic function is relatively preserved. That is basically the difference between the reduced and the preserved ejection fraction. Coming to the pathophysiology, I'm not going to those details. Basically, it is a preload related issues, the contractility related issues, and the afterload related issues. We know when there is a Frank-Starling mechanism, and when the myocytes stretch, and when it reaches 2.2 microns at this particular point, it further comes down. That is the preload dependent. Afterload is also the second important factor. I'm not going to those details. Afterload is also one of the key factors out of the three. The third thing is the pump failure or the myocardial factors. The mechanical abnormalities like the increased preload, central and peripheral, increased volume load, obstruction to ventricular. I will finish into 1 minute or so. Then the myocardial damage, the primary cardiomyopathy, myocarditis, toxicity, and metabolic abnormalities. Secondary will be ischemic inflammation and the chronic obstructive lung disease going related heart failure. So when there is a reduced cardiac output, the compensatory mechanism try to restore the cardiac output by activation of the autonomic nervous system and the neurohumoral system. The Frank-Starling mechanism I have already said. Then the compensatory mechanisms are ventricular hypertrophy, increased sympathetic adrenergic activity, and the renin-angiotensin system. So this is the complex pathophysiology. I'm not going to those details. When the systemic, the sympathetic nervous system will get activated, it lead on to downregulation and decrease in the sensitivity of the sympathetic receptors. That will lead on to impaired inotropic and chronotropic responses. And that is covered, taken care of by the beta blocker. Second is the renin-angiotensin system. And in addition, when the renin-angiotensin system gets activated, simultaneously the natriuretic peptide system is also getting activated, which produces a positive response to the heart failure milieu. Ventricular remodeling is another important thing where you can see this is an example of the post-MI, the infarct zone thinning and the spherical dilatation leading on to impaired ventricular contraction. So at every step of this pathophysiological process, we have different drugs acting. That is the importance of this diagram. can see that when there's a pump failure, you can have inotropic drugs or digoxin. When there is sympathetic nervous system activation, we have the beta blockers. When there is a renin angiotensin system is activated, we have the ACE inhibitors, ARB, and the ARNI. And we have the spironolactone at this point, which will prevent cardiac remodeling. So to conclude, when there is a reduction in cardiac output, initially it will be compensated. The renin-angiotensin system and the sympathetic system will get activated. Later, the compensatory mechanism fail and there is a rising filling pressure. And subsequently, there will be clinical deterioration. And the therapies like pharmacological, electrical, and mechanical will come into action at this particular point in different steps of the pathophysiological process. Thank you.
Thank you, Dr. Harikrishnan, with an extensive coverage of heart failure in the Indian context and a summing up of the pathophysiology of heart failure. The subject is open for discussion, yet extensively covered the younger age group of Indian patients and the higher mortality, higher in-hospital mortality, and various aspects of heart failure like lower incidence of heart failure with preserved ejection fraction as observed in India. Even though we talk about lack of Indian data, we have adequate Indian data to show that the basic facts we have collected mainly from major cities and subordinate sectors. And the subject is open for discussion. Any questions or answers, please?
So if I can start, Hari, that was a very good coverage of the topic. And I think a few very important points that Dr. Harikrishnan brought out. One was prevention. In a country which has got limitation of resources, if we can control hypertension and take care of all the modifiable risk factors and take care of diabetes, stop smoking, exercise, etc. All those things which are well known to everybody, except that they are not implemented. That can have a huge impact on reduction of incidence of heart failure. The other thing is many times it's a conglomeration of several risk factors. A little increase in blood pressure, a little increase in blood sugar, slight increase in cholesterol, a little bit of overweight. So the so-called metabolic syndrome, that increases the incidence of heart disease very, very significantly. And I think that is important because it's a conglomeration of various risk factors which are more significant than sometimes a significant elevation of one risk factor alone. So I think those are some of the important points that Dr. Harikrishnan made. Can I invite in comments from Dr. Manjunath and Dr.
Yeah, it's a very nice presentation, particularly the Indian perspective of heart failure. It's also very nice that a lot of societies have taken up, and it all started with Dr. Harikrishnan, the ICMR study. Then, Indian College of Cardiology is also doing, ICMR is also doing. So it's a very nice thing actually, because all the time we were only reading about the Western literature and about heart failure. Now we have our own data. That is an excellent thing, because we can always customize a lot of things to suit our profile of patients. See, as we know that the commonest cause for heart failure in India is coronary artery disease. Nearly even today, 25 to 30% of patients with acute MI do not get reperfusion therapy within the first 3 or 6 hours. That is where we need to really reinforce this STEMI management in India, because that is the one thing we can really, that is the commonest cause. And particularly the youngsters presenting with acute MI, late presentation, they will have a massive LV damage, maybe due to plaque rupture or just a coronary thrombosis, virtually no collaterals in those group. So the maximum LV damage we see in lot young patients who present like a bolt from the blue sort of a presentation. And another important thing is, yes, definitely rheumatic heart disease is on the decline, but still a lot of people, particularly in northeastern India and North India, still we see rheumatic India, although there is a significant decrease in the prevalence of rheumatic heart disease in South India. That is another thing. So we have to create an awareness, and also we have to, and another important thing, the diabetics patient should undergo proper screening. Many times undiagnosed LV dysfunction we see a lot among diabetics. Then by the time when they present, it's a full-blown picture of heart failure. So these are some of the things we can undertake apart from preventive measures, what has been already dealt. The salt, maybe stress or smoking or spirit and sedentary thing, all this to be taken care of. And most of the thing, there is also a problem. Even a guideline medicated therapy, medical therapy, they are not able to continue because of financial constraint. They take, for example, you prescribe ARNI, they just drop out after 2 months, 3 months. So these are some of the important limitations of guideline medicated therapy. So I think in nutshell, these are some of the great eye openers, and probably the policymakers can take note of this. Thank you.
Dr. Venugopal? Venu, are you there? Welcome, Dr. Rosano.
Hello.
So I think those are very welcome comments. And
Yes.
also the important thing is that, as Dr. Harikrishnan pointed out, our coronary artery disease occurs at a much younger age. So these people are breadwinners for the family, and landing up with a major MI or long-term heart failure impacts not just them, but their earning capacity. The whole family gets affected and has an adverse effect on the society as a whole. Any other comments?
Sir,
Vijay.
there is one question on the chat box, sir. I'm just putting it up for you.
Okay. Okay, Dr. Hari, can you see that?
I can't see that.
So
Okay,
it's a
the
role
role-
of metabolic therapy, like
Role of-
trimethylene, ranolazine, nitrates with isolazine before subjecting to mechanical device.
That and all is coming up in the
Coming
course. We
tomorrow.
will
I
discuss
think
it.
you have, yeah, Hari, I think you have a talk tomorrow.
Yeah.
So all these aspects will be covered in course of time.
Yeah.
So I think let's wind up this session. And
Sir, sorry, sir. Last two questions from the audience, sir.
Go ahead. For categorizing risk of substance abuse, tobacco and alcohol, which tool is used in heart failure patients? We are using ASSIST for categorizing tobacco and alcohol risk, which is low, moderate, and high risk. Who wants to take up? Dr. Hari, this is addressed to you.
Yeah, I think there are different tools available, as she is saying that ASSIST is one of them. And basically, we have to concentrate on the smoking cessation and alcohol cessation, because smoking cessation activities are very few anti-smoking clinics are there in the country. So I think we have to concentrate on such activities. That is very, very important.
I think in the discussion, there's a little undervaluation of the role of systemic hypertension and cardiac failure. Hypertensive heart failure is as important as coronary artery disease and heart failure. And optimal control of blood pressure has to be stressed in the population. Early detection, optimal control of blood pressure. Unless this is done, we will not be able to reduce the incidence of heart failure significantly. It is as important as management of ischemic heart failure. Let us go to the next topic, the patient phenotyping in heart failure. Dr. Rossano, please. Dr. Rossano, welcome to the meeting. Please.
Thank you. Thank you, sir.
Professor Rossano, would you like to do it live? Shall we play back what you have sent us?
Whatever. I mean, whatever you prefer. I mean, I can start from scratch, and I just need to.
No.
You go
Get
ahead
the
and
slide.
please share your screen and go ahead with your talk, sir, please.
Okay, so just give me 1 minute, because I thought you were.
We are
yeah.
ready for the playback if you feel so.
I mean, there's no problem. It's just that I wasn't ready with the slides. So
Dr.
Ready
Rosano is the president-elect of the Heart Failure Association of European Society of Cardiology. He's a dear friend of Heart Failure Association of India and has attended several of our annual meetings. So it's always a pleasure to listen to you, Dr. Rosano.
Thank you, Vijay. It's a great pleasure for me to be here with you, albeit virtually today, and I look forward to come in person next time or whenever it will be possible. So in the next 20 minutes, I will discuss on patient profiling in heart failure. And the reason why we need to do some patient profiling is because if we look at what we do now in patients with heart failure in terms of up titration of heart failure medications, in theory, that will take, say, probably 6 months in order to fully up titrate our medications, because we should start with ACE inhibitors, then beta blockers, MRAs, and then ARNI or SGLT2 inhibitors. And you will, if we look at the guidelines of the European Society of Cardiology, HFA, and I recommend you to log in at the HFA meeting in June, where the new guidelines will be released. And I'm pleased to say that the guideline sessions will be free for all. So it's you can have a glimpse of the new guidelines in June. But for the time being, we know that we need to up titrate ACE inhibitors and beta blockers first. Then, if patients are still symptomatic, reassess them. Then start with an MRA. Then, if they are still symptomatic, then think at therapies like ARNI or ivabradine. But also, when we discuss about patients with heart failure, there is this always the problem that we either have therapies that are approved for the acute phase or for chronic phase, so that most of the drugs have been approved for treatment when patients are stable. So, and we are missing, and the majority of these patients, there are those patients either that are hospitalized and ready to be discharged, or in the early phase post-hospitalization. And this period is very important and is crucial for the treatment of our patients, because as you can see, the mortality and morbidity is the highest within the first 3 months. So when we need a full up titration of medications. We also know that the vast majority of therapies are implemented during hospitalization. And if we look at the results of the 1 year, we see that drugs are initiated in hospital, are maintained. Then if they're not started in hospital at discharge, it is unlikely that they will be re-up titrated. And we also know that it's important, and how it's important, to up titrate and give all medications to all patients, because compared to those patients take one medication, those who take 3 or 4 or 6 medications for heart failure then have a better prognosis. This has been also shown by very recent data from Michael Komajda that looked also at the new therapies and finding that the full implementation of medical therapies led to a very significant further reduction in events as compared to those patients who are taking only an ACE inhibitor and a beta blocker. But the problem is that in reality, we have difficulties in implementing therapies. And if we look at all the different registries, we see that the vast majority of patients take less than optimal dosage of medications, in this case, beta blockers. And this is not because of laziness from this physician point of view, because if you look at this study, there was is the CB-CELD, where there was a forced up titration of medications of bisoprolol. In this case, you can see that only 25% of patients took more than 50% of the target dose. And the main reasons for, say, lack of up titrations were side effects, bradycardia, hypotension. So we have to face the reality. And also we have to think, when we uptitrate beta blockers, that what is important is not the dose that we achieve, but the heart rate we achieve, because those patients with a heart rate at target have a significantly better prognosis compared to patients who takes, for example, 50% of the beta blocker. And looking at a meta-analysis of clinical trials in heart failure, we can see that for the treatment of heart failure, what is important is the heart rate reduction, while the beta blocker dose is not associated with mortality or morbidity. This is true, and this has also been clearly shown by the SHIFT investigators. And in this study, patients were taking either beta blocker or beta blocker plus ivabradine and achieved a heart rate less than 60 beats per minute, did much better than patients that were taking either beta blockers or ivabradine or combination and had heart rate greater than 60 beats per minute. So I think when we talk about beta blockers, we have to think more at an integral effect on heart rate rather than trying to achieve the maximum dose. And also, data coming from different studies, they showed us that the association of ivabradine and beta blocker, for example, is more efficacious in controlling heart rate, in improving left ventricular function, reducing BNP, and also in reducing events. Also, we have to think that in the new drugs that we have for the treatment of heart failure, like the SGLT2 inhibitors. And the beauty of these drugs is that they have a minimal or no impact on heart rate and blood pressure, and therefore they won't affect the implementation of other therapies. But it's important to implement them because their effect on mortality and morbidity, like as shown by the DAPA-HF, is very significant. And also, as shown by the DAPA-HF, they significantly reduce overall mortality that was reduced by 17%. So very significant effect for drugs that do not affect heart rate or blood pressure. And this is a drug that should be regarded in all subsets of patients, in those without diabetes and in those with diabetes, where we have the similar degree of efficacy. Now, the recent data from the Soloist study, they basically showed us that we can start SGLT2 inhibitors in hospital before patients get discharged, and patients receiving sotagliflozin had a significantly lower event compared to placebo. And you can see that the curves start to diverge after 1 or 2 weeks after discharge. So very early, very significant effect for the SGLT2 inhibitors. So all these reasons, I mean, basically suggest us that we have to move away from the old concept of a stepwise approach in implementing medical therapy, and go more into a concept where we can start all the different therapies together or at the short time intervals. This is something that has already been suggested recently by our Canadian colleagues that basically drafted the guidelines where they suggest the use of all new therapies, so ACE inhibitors, ARBs, or ARNI when appropriate, then beta blockers, MRAs, and SGLT2 inhibitors in all patients with heart failure. So there is a rationale for the initiation of guideline-directed medical therapy, and to start them all together. That the first one is a rapid improvement in health status, a rapid improvement in left ventricular remodeling, reduction in hospitalizations, and mortality, as we've recently seen. So moving away from the old concept basically will lead us to save a lot of time, because if we have to take say 8 to 12 weeks to uptitrate beta blockers, another 12 weeks for the beta blockers, then the 8 weeks for the MRAs, and then even more difficult with ARNI that have a significant effect on blood pressure. And then we can see that we can significantly shrink the timing. Of course, that is not an issue for SGLT2 inhibitors that can be started at any time without any significant effect because of the beauty of a single dose administration. But of course, we don't live in the ideal world. We don't live in the ideal world where our patients with heart failure have a normal heart rate and normal blood pressure. The vast majority of patients we see have either low heart rate with different levels of blood pressure, or low blood pressure, or even low heart rate and low blood pressure. Some of them have atrial fibrillation, others have atrial fibrillation, low BP. So we have to think at the different phenotypes, at the different cardiac phenotype of patients with heart failure, and take into account the different phenotypes when we wish to uptitrate our medications. So the proposal that came from the Heart Failure Association is that we need to start in all our patients with heart failure, an ACE inhibitor, beta blocker, an MRA, an SGLT2 inhibitor. Of course, we can consider the ARNI in those patients where is indicated, but I mean, this is the mainstay of therapies. Starting, apart from the SGLT2 inhibitors that have just one dose, starting at the low dose with all the others, and then adjust and implement the medications according to the different profiles. Of course, if we have patients with high heart rate and low blood pressure, then if the target will be to reduce the heart rate, and therefore, rather than increasing the beta blocker dose, and it will be easier and quicker to associate the beta blockers with ivabradine. In patients with low heart rate and low blood pressure, then we have very little space for hemodynamic agents. These are patients that should receive drugs, as mentioned earlier in the questions, like trimetazidine. And also, we have those patients with atrial fibrillation where probably the beta blockers are not as effective as in those patients with sinus rhythm. So you can see that we have different nuances for the uptitration in the different subgroup of patients. And therefore, this is the algorithm that we've proposed with for the phenotyping of patients with heart failure, where we suggest the use of SGLT2 inhibitors, beta blocker, ACE inhibitors, MRA, and diuretics. I mean, we have at the moment just dapagliflozin approved in Europe for heart failure, and we're waiting for the approval of empagliflozin sometime soon. Then, of course, once we start with these drugs, then look at the blood pressure, and then if the blood pressure is maintained or is lower, we will have different pathways. Then the presence of atrial fibrillation, and that will give us different pathways. As what is important is the presence of CKD and hyperkalemia that may influence the use not just of ACE inhibitors, but also of ARNI, because we have to remember that ARNI are not devoid of any effects on renal function. And also then what is important, the heart rate. So it is that from the combination of these different phenotypes and how the different phenotypes will integrate and entangle, then that will we'll need to uptitrate our medications. Of course, in the future, we will be looking at other forms of phenotyping our patients according to epigenomics, genomics, metabolomics, and identifying with through bioprofiling, those patients will respond better to the different medications. But for the time being, we have to stay with what we are. And therefore, what we have, and therefore, basically uptitrate our medications according to the phenotypes. So I think that before concluding, I mean, the therapeutic approach for patients with heart failure has been dictated by the order of which the drug have been introduced in therapy. Now we have to, but that was basically because until a few years ago, we had just few drugs effective in reducing mortality and morbidity. Today, we have many more drugs, and we shouldn't negate these drugs and the benefit of these drugs to our patients, and therefore we should start these medications as soon as possible. Now, of course, if we want to use the old approach, that will take months, if not a year. And therefore, we sort of suggested with the position paper of the Heart Failure Association is due to come soon in the European Journal of Heart Failure. Then we are proposing to start simultaneously all the life-saving medications and up-titrating according to the different phenotypes. Of course, will use this opportunity to invite you all to join the sessions, the free sessions at the Heart Failure Association Congress, and especially day one when we'll be presenting the new guidelines. And I'll be happy to take your questions now. And thank you again for having had me.
Thank you, Dr. Rosano. You hit at the correct spot. If you want to duplicate the results of evidence by clinical trials, you have to use the optimal dose of drugs. That's exactly what you have been stressing. But that optimal dose should be on clinical parameters like heart rate, serum creatinine, potassium, and the blood pressure levels. And looking at the optimal dosage should be depending on the levels of these parameters. But using both these approaches, you can treat all phenotypes of patients with heart failure optimally and improve their outcome in due course. The one point that you stressed, that the mortality in the first 3 months is highest, so that titration of medication post-discharge has to be very carefully done, so that mortality should be prevented as much as possible. That's a very important message you're given. Thank you, Dr. Rosano. That topic is open for discussion. Any comments?
One question which is often asked is, what is the place of digoxin in today's times in heart failure? So I think for our audience, would you express your views?
Yeah, I think it's digoxin can be used. Of course, we leave it as one of the last resources. I mean, because of the evidence now, it's much stronger for the other drugs. I discuss also the issue of patients with atrial fibrillation, and I mean, with the use of digoxin is invaluable in those patients. I would be a little bit cautious, and especially in ladies in small frames, in patients who are frail. I always suggest to check the digoxin levels, because it's sometimes we may see sudden changes in their plasma levels, and that is not just related to their body weight. It's also related to, say, for example, an episode of diarrhea, and episode of sudden dehydration, and changes in renal function. So whenever we use digoxin, the digoxin is a very good ally, and but be careful with the close monitoring.
The other thing that we have seen is that till very recently, it was all about neurohormonal modulation. And now with a host of new drugs coming in with effect on cardiac contractility and SGLT2 inhibitors, and I'm pretty sure that there are new molecules which are coming up, which are going to utilize totally different pathways. There's going to be a profusion of therapies. So I think somewhere, some kind of clarification would have to come as to which therapy for which patients. I mean, if you're going to have about 11 or 12 drugs, does everybody require everything? All the clinical trials have been done stacking the therapy on the previous ones.
Yeah, you're perfectly right. But we've seen from the previous presentation from Dr. Eric Krishnan that the mortality is still high.
Yes.
I mean, it's. I was looking at the data from India. Of course, you have a much severe population, and we have to use whatever we have in order to reduce mortality and morbidity. If that means that we need to use 6 or 7 drugs, I mean, we have to, because that is the only way to curb mortality. Regarding the mechanisms, I'm happy to. I mean, I was very pleased to see the effect of the SGLT2 inhibitors because they act in a different way. And also, we've recently had evidence that they work like trimetazidine as well, for example, by acting on the Krebs cycle. So that probably will lead us to a revival of drugs that have, say, a neutral effect on heart rate and blood pressure that can be easily implemented in therapy. And then they want, without any negative effect on heart rate and blood pressure, leaving a space for the use of the full implementation of ACE inhibitors and beta blockers. Regarding the other drugs working on contractility, I mean, we are all waiting to see whether omecamtiv mecarbil will be approved. I don't know what is the status in India. In Europe, they are still thinking, and I believe the same in America. But I think that it's for very specific patients. So those with very low left ventricular function, especially in sinus rhythm, seems to be very effective. So entirely agree. We need to identify which patient will benefit from which drug, but we need to, at the present, we need to implement all the therapies that have been shown to reduce mortality.
Thank you.
Dr. Yeah, Dr. Manjunath here. See, particularly we have a lot of sick patients in intensive care where ejection fraction is low, requiring intravenous diuretics and borderline blood pressure, say systolic blood pressure around 100 or 90 to 100. So in that context, you can't even start ACE inhibitors, you can't even start beta blockers because they are dependent on intravenous diuretic. So in that category, probably SGLT2 inhibitor has got a role to play as an initial drug. And another thing is, in years to come, whether we should we call this SGLT2 inhibitor as an anti-failure drug or anti-diabetic drug?
I mean, you're entirely right. I mean, we have to use the SGLT2 inhibitors in all patients. I mean, and that will be extremely helpful in the patients you just depicted. And there's no doubt that they're heart failure drugs. And so it's the same thing of Viagra. Viagra initially was sildenafil was developed for coronary artery disease as an antianginal. And then they saw that the side effect probably was better from a marketing point of view. So we have drugs that work on different actions, but the effect of SGLT2 inhibitors in heart failure is so pronounced that we should be regarded as a heart failure drug with, say, glucose lowering effect that also can be useful in diabetes. And for those patients you just mentioned, I think drugs like omecamtiv mecarbil and also trimetazidine are good options. And digoxin.
Dr. Venugopal, any comments?
Yeah, the concept of phenotyping in heart failure management is extremely interesting. I think the groups that you showed, I think that's a way forward rather than simply increasing the drugs according to the maximum dosage. Very often, as you said, with beta blockers, we find that because of bradycardia and hypertension, we are not able to reach the maximum or the guideline said dosage. So what I mean is that this is a very interesting concept of looking at patients with phenotypes and optimizing their medical therapy according to this clinical situations. I think it is a very interesting talk.
Regarding the higher 1 month mortality, the if you do a review of the patient at the first week after discharge and adjust the drugs, it has shown to reduce the mortality significantly. That is one thing which we can easily follow in our clinics. Just follow up the patient in the first week itself. The 7-day follow-up, within 7 days, if you have a follow-up, that has reduced mortality.
You are entirely right, and this is what This is what we do here in the UK. I mean, it's we had difficulties. I mean, I worked for many years in Italy, and it was absolutely impossible to see patients quickly in Italy. But it's the same in Spain, in France, in Germany. So it's if you have a system where you can see patients quickly, then that will be the best way.
Sir, there are a lot of questions on the chat box, sir. We're just putting them up. Professor Chopra and Harikrishnan, sir.
Okay. Once heart failure means heart failure, how to bring back original state? I think original state may or may not return, but you have to use guideline-directed medical therapies to improve outcomes. The only thing is, once there are certain conditions in which this is a reversible condition, for example, certain myocarditis or peripartum cardiomyopathy, those are the ones which are likely to recover. And then there are also some cardiomyopathies with left bundle branch block, where the use of CRT and ARNI and now SGLT2 inhibitors seems to restore LV functions, and mechanistic studies are available.
And this Takotsubo is reversible.
Takotsubo is
stress-induced.
what is the maximum dose of metoprolol? 200 mg. But as was mentioned by Dr. Rosano, many times a patient is unable to tolerate. So more important is to achieve adequate heart rate. If the patient cannot tolerate a full dose of metoprolol, then smaller dose and add on ivabradine if the patient is in sinus rhythm. So that you achieve a heart rate close to 60 per minute. Any role of SGLT2 inhibitors in valvular heart disease? Hari, would you like to say that? Or Dr. Rosano, would you like to say that? And also the role of vericiguat.
Yeah, I mean, for vericiguat, if we find those patients who may tolerate the drop in blood pressure, it's that can be useful. Of course, if we have space to implement the other therapies first, they will give a better and greater benefit. Regarding the SGLT2 inhibitors in valvular heart failure, I mean, I would stick and try to treat 100% of my patients with heart failure with an SGLT2 inhibitor before going into something else. Of course, if that patient with valvular heart disease has also heart failure, there's a clear benefit.
And Dr. Chopra, actually this beta blockers, in fact, Rosanna has given a fantastic algorithm, phenotypic algorithm for those adjustments and this thing. Many patients we have seen going for this maximum dose of beta blockers like a metoprolol 100 milligram twice daily. And I think I can remember, 1 dozen patients coming for pacemaker, temporary pacemaker actually. So most of our patients do not tolerate such a high dose.
Yeah, but I think that in these patients, probably the use of the combined use of beta blocker plus ivabradine is better. So that will allow to reduce the blood pressure lowering and allow a control of heart rate. Because as we've seen, what is important is the reduction in heart rate, not the dose of the beta blocker.
I think these questions will be answered in the next session when we review the topic which we presented today in the first 15 minutes. So don't worry about you can post the questions, the answers will be provided. Since we have...
I think you will proceed with Professor Manjunath.
Yes.
Will speak on evaluation of heart failure with electrocardiogram, chest X-ray, and 6-minute walk test. Dr. Manjunath, please.
Thank you.
And thank you, Dr. Rosano, for your wonderful lecture.
Thank you for having me.
Good evening. I will just take 20-25 minutes just on this particular topic. The role of ECG, chest X-ray, and 6 minutes walk test in the evaluation of heart failure. And already Dr. Hari has very nicely introduced the particular topic as far as the Indian scenario is concerned. So all these three non-invasive, cost-effective, simple tests, ECG, X-ray, and echocardiography, are the basic non-invasive investigation we do in every patient of heart failure or in patients with suspected heart failure. So the value of ECG in heart failure, it provides a etiological diagnosis in many patients, and also it can predict myocardial performance, and it can recognize rhythm disturbances and conduction abnormalities. Prognostication also can be done, and extremely useful in decision making, because decision making is more important than incisions in any subject or in any disease. Again, I repeat, decision making is more important than incisions. So just before coming to this particular topic, just I will roll over Framingham diagnostic criteria for heart failure. We have major criteria, that is acute pulmonary edema, so which is best appreciated on X-ray chest. We have Cardiomegaly 2, then hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea or orthopnea, Ralls, and third heart sound. Then under minor criteria, we have ankle edema, dyspnea on exertion, hepatomegaly, a nocturnal cough, pleural effusion, and tachycardia more than 120 beats per minute. So a lot of things are whatever that has been mentioned under these criteria are picked up on X-ray chest as well as on ECG. And what percentage of patients, because earlier there is a misconception that every patient of chronic heart failure should have an ECG abnormality. So in some of these randomized, prevalence study or in the screening study, nearly 15 to 20% of patients with heart failure have near normal ECG. The take-home message is a normal ECG always do not exclude an heart failure diagnosis. So ECG abnormality is seen in about 70% of patients with heart failure. It is more, normal ECG is more with heart failure with preserved ejection fraction, and about 10% of patients with reduced ejection fraction have a normal ECG. The sensitivity of ECG is around 81%, and specificity is around 51%, and positive predictive value is around 60%. So if you look at the ECG abnormalities, what we get in patients with heart failure, there are about 19 ECG abnormalities that have been listed, starting from some of the rhythm disturbance like flutter, fibrillation, left atrial enlargement, right atrial enlargement, and first degree, second degree heart block, left ventricular hypertrophy, poor R wave progression, abnormal Q waves, left bundle branch block, so also right bundle branch block, left anterior fascicular block, IV conduction defect, non-specific STT changes, and left ventricular strain and ischemic STT changes. So if you look at these, the occurrence of these ECG abnormalities in patients with heart failure, the most consistent and more often found ECG abnormalities are basically those with the left ventricular hypertrophy, and followed by STT changes. So left ventricular hypertrophy, STT changes, then left atrial enlargement, and so also the Q waves. These are the more often findings. Left atrial enlargement is a very important ECG finding in patients with heart failure, because whenever there is an LV dysfunction, there is decreased LV compliance, and there is a elevation of left ventricular end-diastolic pressure. As a result, there is a pulmonary venous hypertension. To get a left atrial enlargement on ECG, there need not be a left atrial enlargement as such. When increase in left atrial pressure itself can give rise to the ECG pattern of left atrial enlargement on ECG. If you look at the sensitivity and specificity of these ECGs, you look at that specificity is very high. It's where among all these parameters, whether it's atrial enlargement, whether it's atrial fibrillation, or whether it is left ventricular hypertrophy, The specificity is very high, from somewhere between 95 to 98, but the sensitivity is low. The abnormal ECG, as already alluded to, is occurring in about 81%, and again STT changes and LV hypertrophy in about 50%. So we have to keep this in mind. So most consistent finding is STT changes and sinus tachycardia and left atrial enlargement, and so also left ventricular hypertrophy. So this is just an ECG to show some of the patients with heart failure do have a QRS widening of more than 150 millisecond, discordant T waves, and no septal Q waves, because there is a septal fibrosis is occurring in many patients with heart failure. So ECG is not only gives information about the status of heart failure, it also useful in decision making. Any patient with heart failure with a QRS duration of 150 with a normal, with normal sinus rhythm with an ejection fraction of 35 is a candidate for device therapy. So it's extremely useful in decision making also, not just for making a diagnosis of heart failure. So this is another important message of ECG in heart failure, particularly with preserved ejection fraction. We can have a normal electrocardiogram, but chances of having a normal electrocardiogram in patients with reduced ejection fraction or severe systolic dysfunction is very, very remote. So the negative predictive value for heart failure with reduced ejection fraction is around 98%. So this is another important ECG, what we deal in patients with heart failure. There is, yes, there are Q waves, there is a persistent ST elevation. Following a myocardial infarction, if there is a persistent ST elevation, it obviously suggests there is an LV apical dyskinesia, which ultimately leads to LV aneurysm. So in that way, we get a lot of information from this ECG. Sometimes when we are doing a stress ECG limited protocol in patients with myocardial infarction, if there is an ST elevation in the infarct-related leads without chest pain, that again suggests these are the patients developing LV apical or LV aneurysm. Sometimes there can be a mimics of heart failure. This is an ECG, you can see here, ST elevation, upsloping ST elevation, also the PR segment elevation in AVR, and it is not fitting into any coronary artery territory. So upsloping ST segment concavity upwards, not fitting into any of these coronary territory, and with PR segment elevation always suggest it could be pericarditis, and myopericarditis can also be a cause of heart failure. Then in massive pericardial effusion, particularly in cardiac tamponade, we get a low voltage ECG complexes, tachycardia, and electrical alternance. So this is how ECG is going to benefit even to rule out chronic heart failure from other conditions which can present with hypotension and tachycardia. Then this is an ECG of right bundle branch block and right axis deviation. S1 Q3 T3 pattern is the classical ECG of pulmonary embolism. So this is very important. The patient presenting with breathlessness, atrial enlargement, you should always give more importance. The patient presenting to the emergency room with acute breathlessness, if left atrial enlargement is very prominent, then you have to think of left heart disease as a cause of heart failure. If right atrial enlargement is remarkable, then you have to think of pulmonary embolism or any other causes of right heart failure. So this is because nearly, as Hari said, nearly 6 to 8% of valvular heart disease contributes for heart failure in India, although these numbers are pretty less in the Western population. So here is an ECG which showing a right axis deviation, left atrial enlargement, so also right atrial enlargement with a right ventricular hypertrophy. So it is not only diagnostic of mitral stenosis, it also gives hemodynamic information. Any patient with the mitral stenosis has got a right axis deviation that suggests patient has got more severe mitral stenosis. As the axis is moving towards the right, it suggests stenosis is more severe. If the axis is moving further, then it suggests patient also has got significant pulmonary artery hypertension. So this is you can see here this is a patient of dilated cardiomyopathy and having this ventricular ectopics. The PVC burden in this case is more than 10%, and MRI was normal. So this is because you can see here these PVCs are negative in negative in AVR and AVL, and positive in 2-3 AVF, suggesting these PVCs are coming from the ventricular outflow tract. In fact, PVC itself, it can be a cause of cardiomyopathy or it can be a consequence of cardiomyopathy. So in these cases, the electrophysiological study will further throw light so that treating these PVCs itself can be a cure for this sort of a cardiomyopathy, which is reversible. So then we have this typical ECG of arrhythmogenic right ventricular dysplasia with the right bundle branch block. You can see here epsilon wave. This is fragmentation of terminal QRS in V1 to V3, suggesting we are dealing with arrhythmogenic RV dysplasia. Then this is a low voltage complex. You can see here, normally the limb leads are basically the unipolar leads. We expect tall R waves in lead 1 to lead AVF unipolar leads. In this ECG, the unipolar leads, the voltage is very low, and so also there are QS complexes in V1 to V6. This is a typical of cardiac amyloidosis. So this is a typical of cardiac amyloidosis because the myocardium is replaced by the amyloid, which has got low electrical activity. So this is typical. This is how ECG is of help in picking up etiological diagnosis. And yes, nearly 10 to 20% of patients present with heart failure with preserved ejection fraction. The most common cause of this particular spectrum is hypertension. So this particular ECG as showing LV hypertrophy, LVH with strain, and so also with the left atrial enlargement. So this is a classic of hypertensive heart failure. Then yes, still in India, we many physicians and we too use digoxin in the management of refractory heart failure when all those combination is not working, because we know that digoxin gives symptomatic benefit, and withdrawal of digoxin studies have shown there is worsening of symptoms of heart failure. Of course, it has no mortality benefit. We agree it has got a narrow therapeutic window. So this bidirectional VT is a very important finding, electrocardiographic finding of digitalis toxicity. So by ECG, you can see whether it's a digitalis effect where you get a mirror image mark of type of ST depression. A bidirectional VT and PAT with block are the two important arrhythmias of digitalis toxicity. So it helps us to monitor digitalis doses in this sort of situation. And we use flecainide also for the management of arrhythmias, which are known to occur in patients with congestive heart failure. So this is a flecainide induced proarrhythmia, and the treatment is obviously we have to give soda bicarb, and then we have to start either if it doesn't respond, then we have to go for pacing. So now ECG also, now this is an era of artificial intelligence and also the machine learning. And we have taken up this project, what is called digital stethoscopes, where ECG is integrated into this, and it can, the machine ECG can predict an ejection fraction, and this is going to be published shortly. So then coming to X-ray, this is another important cost-effective and routinely done non-invasive investigation for the management or in the evaluation of heart failure. congestive heart failure, pulmonary, these are the usual radiological findings we come across: cardiomegaly, vascular redistribution, and diffuse distribution of pulmonary edema fluid, a widened vascular pedicle, increased pulmonary blood volume, septal lines, and pleural effusions. So these are the findings we expect in patients of heart failure, but you may not expect all these findings in every case of heart failure, because each of these findings have their own sensitivity and specificity and a predictive value. So cardiomegaly, by definition, CT ratio of more than 50% is considered to be cardiomegaly. So in a chronic compensated heart failure, obviously the ventricles are enlarged, so also the atrium. As a result, there will be a cardiomegaly. So if you look at these, the prevalence of these findings, you look at these, the most common X-ray finding in patients with heart failure is cardiomegaly. Then pulmonary vein cephalization occurs in about 30 to 40%. Interstitial edema also in about 40%. Alveolar edema is less common, particularly in chronic congestive heart failure. And alveolar edema is more common in acute heart failure than the chronic heart failure. And bilateral pleural effusion, again, is another important finding. And cardiomegaly, as already said, so that is the most consistent finding in patients with reduced ejection fraction. But cardiomegaly may not be there in patients with preserved ejection fraction, because it is basically concentric hypertrophy due to hypertension and decreased LV compliance, at least initially, before preserved ejection patients getting into the category of reduced ejection fraction. You look at the sensitivity and specificity of these X-ray findings. The abnormal X-ray is found in about 60%, and interstitial edema and pulmonary vessel cephalization in 17 to 18%. And alveolar edema is still less, but most consistent finding, more often finding that what we see is cardiomegaly and CT ratio more than 50%. But specificity, like ECG, specificity is pretty high. So what are the grades of pulmonary venous hypertension? X-ray also gives some hemodynamic information with respect to pulmonary venous hypertension. And grade 1, we call it as cephalization, when the wedge pressure is somewhere between 12 to 18, and we get interstitial edema in form of curly B lines when the pressure is around 18 to 25, alveolar edema or a batwing appearance when the wedge pressure is more than 25. So when we think of chronic heart failure, alveolar edema occurs at a higher left atrial pressure than in acute heart failure, such as acute myocardial infarction, acute AR, or acute MR. Alveolar edema can occur at a lower wedge pressure or a LA pressure. So these are some of the X-rays showing the pulmonary venous hypertension. You can see here upper lobe veins are pretty prominent, suggesting it is a grade 1 pulmonary venous hypertension. And again, when the LA pressure starts going up, then we can see the curly V lines of fluid accumulates into interlobar septal lymphatics. And these are the curly C lines that we get basically in the cardiophrenic angle. And SA lines are basically pointing towards the hilum. This is a patient of mitral prosthesis with obstruction with a bat swing appearance, typical of acute pulmonary edema. Why bat wing appearance? So this is basically outer 1/3 of the lung has got a better aeration, a better compliance, and a more efficient lymphatic drainage. So this is just, I wanted to emphasize a patient with a preserved ejection fraction. There may not be cardiomegaly, but you look at this, there is an LV contour. The low outer margin of the LV is convex, that suggests patient has got a concentric hypertrophy, but there is no enlargement. This is typical of heart failure with preserved ejection fraction. And other interesting findings, what we can see in patients with heart failure is LV aneurysm and heavily calcified aneurysm. This again is useful in decision making. in this the patients with refractory heart failure with aneurysm, we have to take out this, what we call it as a DARS procedure. So that is how it guides a decision and guides the future treatment. And again, many patients sometimes, some of the patients have constrictive pericarditis with the heart failure. This is a treatable one. You can see the calcium in the pericardium, just a couple of minutes, and this is pulmonary edema. Then, of course, these are the days of devices, and particularly you can patient on CRT, you can always see on X-ray chest. And exercise, of course, 6 minutes test. Nowadays, it's more popular after COVID. We always do a 6 minutes walk test, look for their saturation, look for any residual lung involvement. This can basically, this is to assess the functional capacity. 6 minutes walk test. It is very I mean, there's no cost involved, but it has to be done in presence of a proper medical supervision. And safety issues in 6 minutes walk test, availability of crash cart, and easy call for help. And it should be part of an ALS trained technician should do this. If on chronic oxygen therapy, continue the same for the test. So summary, ECG is a useful tool to diagnose the cause of heart failure and also diagnose any precipitating factors, to assess the complications in the management of heart failure. And X-ray chest is useful both in the management of heart failure and also to know about the various causes. And 6 minutes walk test assess the global functional capacity and prognosticates patients in heart failure. Thank you.
Thank you, Dr. Manjunath. As usual, Manjunath gives an extensive review of the subject, and he reviewed the electrocardiographic changes with just X-ray and passed on to the 6 minute walk test and its usefulness in management, prognostication of heart failure. The subject is open for discussion, please. Any comments or suggestions? The 6 minute walk test has become extremely important.
Yes.
Because rehabilitating the patient, especially pre-discharge assessment of the patient's exercise capacity, is something very important to evaluate the patient in the outpatient settings.
It's a confidence building measure also. And also we can, when we start on this medication, we can always see whether 6 minutes walk test is better following a particular combination of drugs. So it's useful to monitor the therapy, and also it gives both confidence as well as medically also useful to assess the therapy, because there are so many trials where they have put these drugs, because obviously exercise as such doesn't improve as no mortality benefit, but still it is useful guide to monitor the therapy.
So extremely useful guide, as you said. So extremely useful guide to monitor therapy as well as to monitor the progress of management strategy on the patients and the benefit the patient has accrued. And as you said, stressed earlier, it's a confidence building exercise. The patient gets under supervision, the test is being done. Patient gets a lot of confidence in exercising. The main contribution of the transplantation program, I would say, has been exercising in cardiac patients and the benefit it has on the vascular tree. The benefit of exercise had been evaluated in the last 20 to 30 years. And that is a main change that has happened in the field of management of cardiac failure. 1960s, when I was doing the graduation, patient was not allowed to get out of the bed. The patient has heart failure. Today, it has changed over to programmed ambulation and exercise. And the 6 minute walk test is a good way to evaluate the patient's ability and good method to instill confidence in the patient's ability to go home and continue exercise program.
Yeah, nowadays this cardiac rehabilitation is also called transitional care. So before sending them home, we have to do this test, and also we have to convince medically also whether he's going to be, whether he can go back home with confidence. And at the same time, we can also monitor these parameters, maybe heart rate or even blood pressure, all those.
And Dr. Rosanna, one question to you. How frequent is cardiopulmonary exercise testing utilized in your practice? Is it used routinely or only for research purposes? Can you elaborate?
Yeah, no, we tend to use it mostly for those patients that we're thinking of sending to cardiac transplant or LVAD destination therapy. For the remainder, we use extensively the 6-minute walking test, as said. What is important for the 6-minute though is the way it is conducted, whether and standardized, because it's we have different results according to whether there is say an incentive, there is a nurse pushing the patient, and also the length of the corridor is very important. So I think it's of course, if you have in the individual patient, what is important is to apply always the same test in the same space with the same type of say support if needed, and that will be important. But for cardiopulmonary tests, we will just use it in those patients where we think that they will have to get into a transplantation waiting list or in an LVAD destination therapy.
Actually, this 6 minutes walk test has become very popular because of COVID-19 pandemic. Because nowadays, they always test saturation after 6 minutes walk, and even also as a discharge policy where there is a lung involvement, they do that. Even when they go back as a part of rehabilitation, pulmonary rehabilitation, they are doing this 6 minutes test. So all of a sudden, it has become very popular protocol.
Or 10 years back when we introduced ambrisentan,
yes,
it's just as the most important thing, so that patient gets a feeling that ambrisentan has benefited them.
So Manjunath, these days with the COVID, most of the patients, when they come to the emergency, then they go to the scan department, CT scan, almost like trying to figure out how severe their COVID is. The absence of pleural effusion is a hallmark almost of COVID-19. So when patients who come with shortness of breath and have COVID-19, and even before echo is done, does it help in differentiating between heart failures and COVID in these sort of patients?
Anyway, pleural effusion is basically, if it is there, it's more often an heart failure, okay, or maybe the non-COVID type of pneumonia, something like that. But only thing is, chest X-ray normally underestimate pleural effusion. Many a time we have seen patients extremely, there is a deterioration of their symptoms, and the chest X-ray shows just the blunting of cardiophrenic angle, just this thing. If you do an ultrasound, then the pleural fluid is somewhere around 500 and 600 ml. So definitely chest X-ray underestimate the pleural fluid quantity. So ultrasound chest is very important as a follow-up if there is a worsening of symptoms.
But its presence itself is indicative in heart disease, indicative of left heart failure, with bilateral blunting of the costophrenic ankles.
Yeah, the ultrasound, the B lines is very popular and is being developed.
Lung ultrasound.
Lung ultrasound, yeah. It's a very popular tool which is evolved, and it requires very minimal training for an echo technician to do.
Correct.
Yeah.
All right.
No questions in the chat box. There is one there. Yeah. No questions in the chat box.
No, sir. There are no questions on the chat box, sir.
Yeah.
So I think we are on
we had
time.
a very useful session.
Yes.
A very useful session with Hari Krishnan detailing on the Indian context of the heart failure, the scope of the problem, and how to tackle it, and the pathophysiology. And Dr. Rossano beautifully describing the phenotyping of the patient in terms of management strategy. How to titrate the drugs, how to titrate the paraclinical parameters. And Dr. Manjunath dealing with the electrocardiogram, the chest X-ray, and the stress test, 6-minute walk test in the management of cardiac failure. I think we covered a lot of areas in heart failure today. And I think I would like to thank the faculty members first. Dr. Harikrishnan, Dr. Rossano especially, because he has emphasized on a very particular important point, and Dr. Manjunath for extensively covering the ECG and chest X-ray. And would like to thank all the audience who has listened to, how many, I don't know, a large number registered, how many listened to, I don't know, probably more than 100, I think.
No, 300 plus.
300. It's a good number of audience. I would like to thank all of them for listening to this discussion, because I'm sure it must have definitely benefited you for your clinical practice. Thank you. Thanks, everybody. And I'll hand over the mic to Vijay Chopra.
So I think it has been a fantastic session. Regardless of how much we think we know, there's always something new to learn every time you listen to the experts. So thank you, Dr. Rossano, Manjunath, Hari, and a lot of thanks to the audience for participating. And it has been our endeavor, and it will continue to be, to improve the care of heart failure patients in our country by utilizing whatever means we can. Thank you very much, and see you at the next session. Good night.
Next session will be next Wednesday at 7 p.m.
Yes.
Good night.
Thank
Good
you.
night, everyone.
Thank you. Good night.
Good night, Dr. Rossano.
Thank you.